This is EHJ today at the Cardiology update in Davos, Switzerland, and I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal, and I'm talking today to Jean-Luc Vachiery from the Free University in Brussels. Welcome.
Thank you.
So you have a strong interest in heart failure and pulmonary hypertension, and I think today we want to focus a little bit on the latter. So what is pulmonary hypertension?
Yeah, thank you, Tom. I mean, pulmonary hypertension is a clinical syndrome of dyspnea and fatigue that is due to an increased pressure in the lungs. It's a hemodynamic definition, so you need the right heart cath to make the diagnosis, and it's defined as a mean PA pressure above 25 millimeters of mercury. So that's basically the definition of pulmonary hypertension.
So the systolic pressure doesn't suffice in echo?
No, you need a cath. This is probably one of the very few disease areas where we still need right heart cath to define. Yeah.
And so once you made the diagnosis, what are the subsets of pulmonary hypertension?
So we have 5 different groups. Group 1 is called pulmonary arterial hypertension, which is the one in which there has been a lot of investment in research. It's a rare disease. Obviously, half of the cases are idiopathic or irritable. Patients have also associated conditions that predispose them to develop pulmonary hypertension, congenital heart disease, systemic sclerosis, portal hypertension, HIV, etc. Then you have a second group, which is called pulmonary hypertension due to left heart disease as a cause. So in this case, pulmonary hypertension is a symptom of the underlying condition. Group 3, lung disease. Group 4, very important one, chronic thromboembolic pulmonary hypertension. One of the very few conditions that we can treat by a very effective surgery. And group 5 is a mixed box where you put everything that you cannot put in the other ones.
As usual, yes. Yeah. So let's focus a little bit on primary pulmonary hypertension. These are usually young patients, huh?
Well, in the past, we had that profile of young female. Now, things are changing now that we encompass a little bit more than just what was called primary, now called idiopathic. So it's a bit more like patients are getting a little bit older. The mean age is about 50. There's still a female prevalence. Obviously, in most of the conditions associated with PH. But it's definitely a deadly disease. So the lifespan of a patient who has group 1 pulmonary arterial hypertension is probably a median survival of about 3 years without treatment.
So it's like
very
a
deadly.
cancer?
It's like cancer, yeah.
Yeah, it's very bad. So what are the causes?
Well, in most cases, half of the case we don't find a cause. It's just like sporadic increased pulmonary vascular disease developing without any cardiac cause.
Arterial hypertension?
For example, yeah. But some of the causes, as I said, scleroderma, HIV patients. So scleroderma patients are tricky. Right. 10% of them do have pulmonary hypertension. Heritable forms are now growing. We made a lot of progresses in genetic assessment, and we now have genes that are acting as predisposition to develop the condition. Very important.
Right. What are the most important genes?
Well, BMPR2 mutations, SMAD mutations, AQN, caveolin-1, which is also one that has been recently discovered as being predisposing. Of course, none of them are neither necessary nor sufficient to develop the disease. But when you have 2 cases in the family with a genetic mutation, then the pressure would increase in the other members of the same family.
During the course, it becomes more rigid and less responsive to vasodilators. So how important is the vasodilator test when you do the right heart catheterization?
Very important. It remains a very important way to make the diagnosis and also embark on treatment, because when you have a true responder, this patient will have an outcome that is fairly different from the others. Yeah. True responders mean that the mean PA pressure needs to drop below 40 millimeters of mercury with a normal or increased cardiac output. And a true responder is typically somebody who would completely or near normalized hemodynamics. Wherever the patient starts, the pressure would go down under nitric oxide, which is our preferred agent to test. Okay. Those patients can get vasodilators. The others must go on PH-approved drugs or specific therapies.
Okay, let's you take a nitric oxide inhalation, and so let's say it normalizes. What do you give the patient then?
Calcium channel blockers, clear indication, high doses. Well, the most studied have been nifedipine and diltiazem. Some centers use amlodipine. There's no clinical trial there. So it's a little bit one of the threes that I mentioned that are used primarily. Clearly, in a patient who has high heart rate, I mean, you can consider using diltiazem instead of nifedipine. Yes. And then you go high on the doses. So we're talking about 1,200 milligrams or 200 milligrams of nifedipine if the patient can tolerate. So you need to up titrate. If the patient tolerates the drug, and if you control the hemodynamics, you will have a long-term responder, acute responder with nitric oxide, long-term responder to calcium channel blockers.
Okay, let's assume he doesn't respond well enough to the calcium channel. What's the next step?
Next step would be to go on specific therapies, endothelial receptor antagonists, nitric oxide pathway modulators, whether it's PD5,
like sildenafil,
for example, PD5 inhibitors, sildenafil, tadalafil, or yosiguat, which is a soluble guanylate cyclase stimulator, or you can go on prostacyclines. I'm saying or, but now we know that it can be and, because we have now a clinical trial demonstrating that when you're combining two oral treatments, at time of diagnosis you improve outcome dramatically as opposed to a monotherapy.
There was also a trial showing in the New England that if you use endothelial antagonists that you improve mortality. So when do you use those? Yeah,
well, actually you have the choice, because in this study specifically 60% of the patients were already on background with a PD5 inhibitor, but 40% of the patients were naive. So you can use it as first line monotherapy or second line in combination.
And let's assume the patient does not respond to nitric oxide in the initial cardiac catheterization. What do you do then?
Then we would go on those specific therapies
immediately. Then calcium antagonists usually don't work.
No, they don't work. Most of the I mean, the responders, you find them in the small subgroup of idiopathic cases, and only 10% of those patients will have a long-term response. So we're talking really about the tip of the iceberg of pulmonary arterial hypertension. Nevertheless, if you have a patient who has a response, you really need to treat that patient with calcium channel blockers, because specific treatment don't work as well. It seems that in some patients, the vasodilation, vasoconstriction component is really predominant as opposed to remodeling, which you would see in more severe cases.
Right. What about other treatments like anticoagulation?
Well, that's a very important topic. There's been a debate recently about the role of anticoagulation in terms of improving outcomes. So we are currently discussing the next recommendations that will be published in later this year. The consensus here that is coming from experts is that we would reserve anticoagulation to idiopathic, heritable, and drug-induced forms of pulmonary arterial hypertension. This is where we have the most robust evidence.
And what about transplantation?
Good option as well. So it's different maybe from one center to the other. At our center, we do consider transplant from scratch in severe cases, no doubt. If a patient doesn't have a contraindication, it's very likely that eventually the patient may benefit from a transplant. So typically transplant is reserved for patients who, of course, don't have a contraindication and who are failing or rapidly deteriorating under medical treatment.
What does the practicing cardiologist need to know? How does he pick up these patients?
The gatekeeper is the echocardiography, clearly. So when you have signs of increased pressures and signs of right ventricular insult, then the patient should be worked out for for the diagnosis of pulmonary hypertension.
And refer to a specialized center. Huh?
It's preferable. Once you, of course, not if you have obvious mitral stenosis or something like that, but if you don't have any cardiac or respiratory cause, if you have pulmonary hypertension detected at echo, the recommendation would be to send a patient to an expert, yes.
Thank you very much indeed.
Thank you.